Hi everyone, in this video we will be talking about breast cancer risk assessment. We will be focusing on breast cancer risk factors including family history. We will also be focusing on iPrevent as a tool for breast cancer risk assessment, and we will also touch on breast cancer risk reducing medications. So we'll start by talking about breast cancer risk assessment. So to do a breast cancer risk assessment, the first thing you must do is to confirm that the patient does not have any potential symptoms of breast cancer. And this is because if the patient has any symptoms of breast cancer, then that means the patient should have a diagnostic evaluation rather than a screening or risk assessment. Here are some symptoms for potential breast cancer. Breast lumps or axillary lumps, especially if it is unilateral. Any change in the size or the shape of the breast. Any nipple changes such as crusting, inflammation, retraction, or ulceration, and any nipple discharge, especially if it is bloodstained or serous discharge that occurs without squeezing, i.e. spontaneously. Any skin changes such as redness, dimpling, pulled orange, or puckering or tenting or tethering of the skin, and any breast pain, especially if it is persistent and localized. This here is an infographic from the Cancer Council of Western Australia, and it shows the probability of breast cancers based on the clinical features that the patient may have according to their age to determine the likelihood that these symptoms could predict breast cancer. And so the symptoms are breast pain, nipple discharge, nipple retraction, and breast lump. And you can see that the risk or the probability of these symptoms being breast cancer goes up with age, and that the symptom that provides the highest risk, regardless of age group, for breast cancer prediction will be breast lump. So as an example, the probability of breast cancer from a breast lump at age 40 to 49 years is 4.8%, and this jumps up quite significantly to 48% for a woman that is 70 years or greater. The Cancer Council of Western Australia also recommends that anyone that falls in this red category, that is, they have a breast cancer probability based on the symptoms of greater than 5%, to be urgently referred to a specialist, which means that most patients above 50 who have symptoms of breast cancer, you need to be quite suspicious of them potentially having breast cancer. This is an information graphic taken from the Cancer Council of Australia, and it highlights different risk factors for breast cancer. So we'll start with personal risk factors, of which age is a very important risk factor. The older you are, the higher your risk of getting breast cancer. And you can see here that a 50-year-old compared to a 30-year-old has a relative risk ratio of developing breast cancer of 10, greater than the 30-year-old. Breast density also is a risk factor for breast cancer. If you have moderately dense breasts, you are at increased risk compared to someone with averagely dense breasts. And if you have a non-dense breast, it is a protective factor for breast cancer compared to someone who has a higher breast density. In terms of medical history and medications, combined oral contraceptive pill is a risk factor for developing breast cancer, particularly after 5 years of concurrent use of the pill. So you need to be currently using the pill and have used the pill for more than 5 years, because if you stop using the pill, your risk for breast cancer from the pill actually abolishes. Likewise, patients taking combined menopause hormone therapy have a higher risk of breast cancer compared to people who have never taken MHT. However, the risk increases after many years of use, and it usually isn't very significant for patients who only have been taking it for 1 to 2 years. Exposure to DES while pregnant is another risk factor for breast cancer, although this is less common nowadays. Reproductive factors that are risk factors for breast cancer all relate to the cumulative exposure to cyclical estrogen and progesterone, such that the more that a woman is exposed to cyclical progesterone and estrogen, the higher their risk of getting breast cancer, which is why risk factors for breast cancer are late menarche, having late pregnancy or not having children, not breastfeeding, and a late menopause, because all of these factors are associated with a higher cumulative exposure to cyclical estrogen and progesterone. So late menarche, not having children or having children late, not breastfeeding, and a late menopause age are risk factors for breast cancer compared to early menarche, having an earlier child, breastfeeding, and an earlier age of menopause. In terms of family history and genetics, a family history of breast cancer increases your risk of developing breast cancer, which is quite obvious. And this risk increases the more number of relatives you have with breast cancer, as well as it is also higher for a first degree relative compared to a second degree relative. Genetic mutations. There are also certain genetic mutations that increase your risk of breast cancer quite significantly so. The most well-known ones will be the BRCA1 and the BRCA2 gene. There are also other genes such as the PALB2, the TP53, and the PTEN gene, which, if mutated, can significantly increase your risk of breast cancer. Lifestyle factors that increase breast cancer, which are the ones that we can change and alter and modify, will be an elevated BMI. So someone who has a higher BMI has a higher risk of breast cancer. If you have a high alcohol consumption, that is also a risk factor. And being physically active is a protective factor for breast cancer. And obviously smoking is a risk factor for breast cancer. Now we'll talk about breast cancer risk based on family history. And so based on a patient's family history, you can categorize them into 3 categories of risk levels. The lowest one is an average or slightly increased risk. The middle one is a moderately increased risk. And the third category is a high risk. Essentially, when you should start having your alarm bells go off that a patient could be at moderately increased risk or higher of breast cancer based on your family history is if they have at least 2 relatives on the same side of the family with a breast cancer history, whether or not they are first or second degree relative. To make it easier to understand when a patient could fall under moderately increased risk, there's this flag system here that I've come up with, where you need to have 3 flags in order for someone to be classified as moderately increased risk. And you have a flag if you have a first degree relative. So if you have 2 first degree relatives, you'll have 2 flags, 1 for each. If you have a first degree relative under 50 years of age, that is 2 flags. If you have 2 second degree relatives, that is 1 flag. And if you have a second degree relative under 50 years of age, that is another flag. And if you have 2 family members with breast cancer on the same side of the family, whether they are first or second degree, then that is another flag. So let's go through some examples of what a average or slightly increased risk family history pertains. So for patients who are at an average or slightly increased risk of breast cancer, it means that their risk of developing breast cancer is less than 1.5 times the population risk. So no more than 1.5 times the population risk. This translates to a 9 to 12.5% lifetime prevalence of breast cancer. So if they have only 1 family member with breast cancer above 50, then that does not qualify them to be at moderately increased risk. If they have 2 second degree family members above 50 on the same side, that only qualifies them as 2 flags, so not quite 3 flags. And likewise, if they have 2 first or second degree family members above 50, but yet they're on different sides, then that is also 2 flags. For every patient, what you need to do is you should recommend them to clarify their risk of breast cancer using the iPrevent calculator. You need to advise patients to know the normal look and feel of their breasts and to report any symptoms to their doctor. And you should always discuss modifiable risk factors such as weight loss, smoking, alcohol, and physical activity to reduce their risk of breast cancer as much as possible. For patients who come under this average or slightly increased risk of breast cancer category, the recommendation is for them to have normal breast cancer screening. That is, from the ages of 50 to 74, they should have a breast screen mammogram every 2 years. And if they are 40 to 50, they can opt in to have a mammogram should they want to after discussing with their doctor. For patients at moderately increased risk, it means that they are at 1.5 to 3 times the population risk, and this translates to a 12 to 25% lifetime prevalence of developing breast cancer. Essentially, for these people, they will either have a 1 first degree relative under 50, which will automatically put them at 3 flags, 1 flag for having one first-degree relative and 2 flags for having a first-degree relative under 50 years. If you have 2 first-degree relatives on any age on the same side of the family, that's also 3 flags. 2 flags, 1 each for each first-degree family member, and then another flag for them being on the same side of the family. Or if you have 2 second-degree relatives on the same side with at least 1 under 50, that's also 3 flags. So if you have, that's 1 flag for having 2 second-degree relatives, another flag for them being on the same side of the family, and another flag for them being under 50 years. Similar to the average risk population, clarify their risk using iPrevent, discuss modifiable risk factors, and advise the patient to be breast aware, so to know the normal look and feel of their breast, and report any changes or symptoms to their doctor. For patients who fall in the moderately increased risk category, you need to advise them that a more precise risk assessment and management plan is available from a familial cancer clinic. And if they want a referral, then we should facilitate this as a referral for them. You don't have to refer them if the patient does not want to. For patients at moderately increased risk, the recommendations for breast cancer screening is that at the age of 40 to 50, they should have at least a mammogram every 2 years, if not every year, if they have a family member with breast cancer under the age of 50. But once they hit 50, they go back to the same breast cancer screening program as the standard population, where they get a mammogram every 2 years. So the only real difference here is that when they turn 40, they should get screening at least every 2 years with a mammogram, if not at least every year. For the high risk category, they have a 3 times greater risk compared to the population average. And this translates to a 25 to 50% lifetime prevalence of breast cancer. To qualify for the high risk category, you need to have at least 2 members, whether or not they're first or second degree doesn't matter. They need to have at least 2 family members on the same side of the family with either breast or ovarian cancer, plus one of the following on the same side of the family. So they'll have an additional qualifying factor on the same side of the family that will bump them from a moderately increased risk into the high risk category. And there are 6 categories, there are 6 criteria that will bump them into the high risk. The first is an additional relative on the same side of the family with breast or ovarian cancer. So they have 3 family members with breast or ovarian cancer on the same side of the family. If one of the family members has a breast cancer under 40, if they have bilateral breast cancer, if they have breast and ovarian cancer in the same woman, or breast cancer in a male relative, or if they are of Ashkenazi Jewish ancestry. So additional relative with breast or ovarian cancer, breast cancer under 40 years, bilateral breast cancer, breast and ovarian cancer in the same woman, breast cancer in a male relative, or Ashkenazi Jewish ancestry. Another qualifying factor would be they have 1 family member, whether first or second degree, with breast cancer under 45 years, plus another family member, first or second degree, on the same side of the family with a sarcoma under 45 years. The third category is that they have a family history of a family member with a high risk breast cancer mutation, and usually that would be a first degree relative. An example would be the BRCA1 and BRCA2 mutation. Again, for these patients, clarify their risk using iPrevent. We advise them of breast awareness to know the normal look and feel of their breasts and to report any changes or symptoms to their doctors, and to discuss modifiable risk factors. For these patients at high risk, the recommendation is that they should be referred to a familial cancer clinic. Compared to the moderately increased risk category, where you can tell them of the option of referral, those with high risk should be referred to a familial cancer clinic. And at the clinic, they may consider things like genetic testing for germline mutations, supplemental imaging such as with MRI, chemo prevention with SERMs such as tamoxifen or aromatase inhibitors like anastrozole, and consider prophylactic mastectomy or salpingo-oophorectomy if they are at really, really high risk. But if a woman declines the referral, which is well within their rights, and they prefer to continue screening with breast screen, then the recommendation is that when they turn 40 all the way up to 50, they should have a mammogram every year, and then from 50 to 74 they return back to the normal screening program every 2 years. But they ideally should be referred to a familial cancer clinic. And so here's a summary again. If you're at a population risk between 40 and 50s, at least second yearly mammograms are optional, not recommended, only if the patient wants to. If they're above 50 years, then the standard 2 yearly mammograms are recommended. Moderate risk, when they turn 40, we recommend annual mammograms. And if they're at high risk, then you refer them to a familial cancer clinic. If not, then annual screening from 40 to 50 and biannual screening from 50 to 74 years of age. So the next is iPrevent. So iPrevent is a web-based application that estimates a woman's breast cancer risk and provides information about breast cancer screening and breast cancer prevention and risk reduction information that is personalized to that particular woman. iPrevent will ask the patient to put in some data about breast cancer risk factors, including their reproductive factors, lifestyle factors, any personal history of previous breast disease, especially lobular carcinoma in situ or atypical hyperplasia, and their family history, especially if they have a family history of breast, ovarian, prostate, or pancreatic cancer. If preferable, the patient should put in an exact age of diagnosis for their family members, but you can also provide an estimate. But even if they have no idea about the age, they can still proceed by just putting the family member that is affected with the cancer without needing to put in their age. iPrevent will give them a 10-year risk percentage, so a percentage of developing breast cancer over 10 years, as well as a residual lifetime risk of developing breast cancer. They also will compare that particular patient's individual risk to the average population risk for a woman of the same age. iPrevent will then provide them with screening and preventative options based on their risk level, such as a risk-reducing bilateral mastectomy, a risk-reducing salpingo-oophorectomy, risk-reducing medications like tamoxifen or anastrozole, information about breast cancer screening, and information about lifestyle modifications such as losing weight, reducing alcohol, or smoking cessation. iPrevent basically applies the following risk reductions to both the residual lifetime risk and the 10-year risk for that patient based on the interventions that they're recommending. So according to iPrevent, a risk-reducing mastectomy reduces the risk of breast cancer by 90%. A salpingo-oophorectomy prior to 45 years of age has a 50% risk reduction. 5 years of tamoxifen, 33%. 5 years of raloxifene, 25%. And 5 years of anastrozole or exemestane, 50% reduction. So this here is a report that iPrevent has provided for a patient that is of average risk. We will also go through reports for patients at moderate and high risk, but this is an example to see how the report looks like. So for this, the patient has put in their details, so their age, their BMI, their age of menarche, their menopausal status, whether or not they've had any breast investigations or genetic testing, and their lifestyle factors such as any smoking or alcohol, which in this case the patient smokes and drinks 24 standard drinks a week. They put in their family history and family members who have either breast, ovarian, pancreatic, or prostate cancer. So for example, for this patient, they have their maternal grandmother who was diagnosed with breast cancer at 75 years of age. Because they only have one second degree relative with breast cancer, they don't even have a flag really, and so they are considered to be at average or slightly above average risk. iPrevent will then give them information about their breast cancer risk. Because they fall in the average risk category, they do not provide them specifically with a 10-year percentage risk or a residual lifetime risk percentage. They simply state that the risk of developing breast cancer is about average for a woman of your age, and they show a pictogram to help the patient understand it better. They then provide information about screening mammograms, and so because this patient here is 25 years of age, they have recommended that screening mammograms are not recommended. But once you turn 40, you can discuss mammogram screening with your doctor. They also provide information about breast awareness and lifestyle factors to help minimize the risk of breast cancer. So for example, in this patient, her BMI is 27.6, so their recommendation is to reduce their weight, reduce their alcohol consumption, and to quit smoking. And also, they've put in the information here that if they consider using HRT, then to use it for as short of a time as possible. This one here is the report for a moderate risk for breast cancer. In this case, it's a 60-year-old postmenopausal lady with quite a significant family history of breast cancer and ovarian cancer. So she has had a maternal grandmother with ovarian cancer, a paternal grandmother with breast cancer at 69. She has a first-degree family with her mother with breast cancer at 64 and a sister at 65. And so she has at least 2 family members, so then we should perk up and think that she is at increased risk. But however, she has 2 family members first degree and 1 family member second degree. However, none of them meet the additional criteria for putting her at the high risk. So she doesn't have a breast and ovarian cancer in the same woman. There is no family member who is male with breast cancer. There isn't any family history of breast cancer bilaterally. There's no history of breast cancer under 40. There's no history of Ashkenazi Jewish ancestry, and there isn't another family member on the same side of the family with breast cancer. So she's had 2 on her mom's side, which is her mom and her sister, but the other person who has breast cancer in the family is on the father's side. So there isn't 3 on the same side. There is 2 on the mom and 1 on the dad's side, and so that doesn't qualify her to be in the high risk category. iPrevent will then tell this patient of their risk, both the 10-year risk as well as the residual lifetime risk, and in this case it is 6.7%, 10 years, and 11.4%. This puts her at the average risk. They put some information about being referred to a familial cancer clinic, and so this patient is in a moderate risk category. They can consider referral to a family cancer clinic should they want to have a more precise risk assessment and calculation. They also provide information about the patient's ovarian cancer risk, essentially saying that because you have a family member with ovarian cancer, you are at an increased risk. And so that's something they should be aware about. They provide information about screening. So this lady is 60 years old at moderate risk. And so iPrevent has actually recommended them to have yearly screening mammograms. If you follow the Breast Screen Victoria recommendations for a moderately risk woman of breast cancer, they would actually recommend 2 yearly mammograms from 50 to 74. But in this case, iPrevent, because it's more personalized for this woman, has actually recommended her to get yearly screening mammograms. Again, the same thing about breast awareness and lifestyle factor education to minimize the risk of breast cancer is provided. iPrevent also provides information about risk-reducing medication to this woman. Because this woman falls in the moderately increased risk category, she is potentially eligible for risk-reducing medications to reduce her risk of developing breast cancer through primary prevention. Essentially, they say that she may be eligible and that she should talk more with her doctor. This one here is a report for a patient that is at high risk based on their family history. So this is the patient's details. She's 44, so-and-so, and based on her family history, she has a significant family history of breast cancer. So she has breast cancer in her maternal grandmother, above 50. She has her mom has breast cancer at 58 and a second breast cancer at age 63. So she has bilateral breast cancers. She also has a maternal uncle. So an uncle on the mom's side with prostate cancer. That's not as relevant. She has 2 sisters who both have breast cancer at 40. So she already qualifies for the high risk category because she has at least 2 first or second degree family members with breast cancer on the same side of the family, which is her mother and her mother's mother. But she also has an additional qualifying factor based on the fact that she has another relative on the same side of the family, which is her sister. Both her sisters actually having breast cancer and quite at a young age of 40. iPrevent then spits out this woman's breast cancer risk, which is very high. The next 10-year risk is 39.1% and a lifetime risk of 78.3%. If you can remember, the lifetime risk of developing breast cancer for a high risk category patient is 25 to 50%. So this woman's lifetime residual risk is 78.3%, which is much higher. than the high risk category in general. So they recommend this patient to be referred to a family cancer clinic. They also recommend that this patient be referred for supplemental imaging, such as with MRIs, breast awareness, and lifestyle factors, which is the same as the other risk categories. They've also additionally recommended this woman to be aware potentially that she may be eligible for a risk-reducing mastectomy, as well as risk-reducing medications, and also she may be eligible for a risk-reducing salpingo-oophorectomy. And essentially they recommended that this be discussed with the patient and that the patient have this discussion with their specialist. So here's a summary of risk-reducing options according to the risk category for the patient. So for patients to be eligible for risk-reducing mastectomy, they need to be in the high-risk category. For them to be eligible for a risk-reducing salpingo-oophorectomy, they must be under the age of 45 or below. They have to be high risk and they have to have a BRCA1 or 2 mutation. Or they are 45 years of age and below. They are high risk category and they have at least one relative with ovarian cancer. For risk-reducing medication, the recommended eligibility is for premenopausal women to be moderate risk and at least 35 years of age, and also women of high risk should be considered for the risk-reducing medications. For postmenopausal women, exactly the same. If you are at least moderate risk and 35 years of age or high risk, then you can be considered for the medications. Screening should be for all women, and lifestyle should be for all women to reduce their modifiable risk factors. So now we will talk about breast cancer risk-reducing medications. So breast cancer risk-reducing medications have a very good, strong body of evidence of efficacy for the primary prevention of breast cancer, more specifically to reduce the risk of estrogen receptor positive breast cancer. It is a daily tablet that is taken usually for 3 to 5 years, and there are 4 different medication options for women, only one of which is available for pre-menopausal women, and that is tamoxifen, which can be used for both pre and post-menopausal, whereas the other 3, raloxifene, anastrozole, and exemestane, are only used for post-menopausal women. And the definition of postmenopausal women for these medications is the patient is either 60 years or older, they've had a history of a bilateral oophorectomy, or they have a uterus and they're under 60, but they've had amenorrhea for 12 months without any other cause, which is the normal definition of menopause. Or if they're under 60, but they don't have a uterus to tell you whether or not they have amenorrhea, they need to have an FSH level of at least 30. So breast cancer risk reduction medications are recommended by Australian and international guidelines for breast cancer prevention. It should be a standard of care for women who fall within the moderate risk category, which is greater than 1.5 times the population risk. These medications reduce the relative risk of breast cancer by 30 to 60%, and this risk reduction has benefits even after the patient has stopped the medication. So for example, the patient may only need to take tamoxifen 20 milligrams for 5 years as part of the prophylactic course, but this reduces the patient's risk of breast cancer for at least 20 years. And note that women prescribed these medications should still continue to undertake breast cancer screening that is appropriate to their age and risk level. So again, this breast cancer risk-reducing medication is an option for high-risk women who don't want risk-reducing mastectomy, for women who are at increased risk but they're not high enough of a risk to be considered appropriate for surgery, or women with a breast cancer risk greater than 1.5 times the normal, which is the moderate risk category. And there is 20 to 25% of Australian women who will fall into at least the moderate risk category. So that's a significant number of women that may potentially be eligible for these medications to help reduce significantly the risk of developing breast cancer. To help with the process of initiating patients with breast cancer risk reduction medications, there is a service provided by Peter Mac for Victorian women called the Preventing Cancer with Medication Services. So PCMED is a free telehealth service led by medical oncologists where they will discuss the risk and benefits of these medications with the patients. And it's a service that the patients can be referred to by their GP. The specialist will initiate medications and will discharge them back to the GP to complete the treatment course. The specialist will review them about 8 to 10 weeks post to ensure that the medications are well tolerated before discharging them back to the GP. Information is then given back to the GP on the treatment plan, the medication itself, as well as how and when to refer back to the service. And the GP will provide ongoing prescriptions for these patients, which are usually for 5 years. And there is a dedicated telephone hotline for the GP to seek advice from this service, should they need to. The eligibility criteria for PCMED is that, firstly, the patient must be willing to consider these medications. If they have no interest in taking these medications, then there's no point referring them for a service that they will not use. They need to be female. At birth, they need to be between the ages of 20 to 70 years, and they should not have any personal history of invasive breast cancer or ductal carcinoma in situ, because these medications are for primary prevention, not secondary prevention of breast cancer. And the patient must not have a history of bilateral mastectomy, because the benefit of reducing breast cancer risk in a patient with no breast tissue is minimal. They also need to have one of the following factors to indicate an increased breast cancer risk. So the first is that they need to have a residual lifetime breast cancer risk of at least 20% via an iPrevent calculator, but other calculators that are validated include the CAN risk and the IBIS calculator. The other criteria will be 10-year risk of at least 5%, or a history of LCIS or atypical hyperplasia, or they have a history of prior thoracic radiotherapy before the age of 35, and that the radiation was at least more than 5 years ago. They do not need to require germline genetic testing to further clarify the risk of breast cancer, but if the patient is high risk based on their family history, then they should be referred to a familial cancer center anyways. But those high-risk patients should also be referred to PCMED for consideration of breast cancer reducing medications. So this here is a table that goes through the 4 different medications to help reduce breast cancer risk as primary prevention, and these are tamoxifen, raloxifene, which are both selective estrogen receptor modulators, and then we have exemestane and anastrozole. So we will talk about each one of these medications with regards to their breast cancer risk reduction efficacy, their risk of endometrial cancer, their risk of venous thromboembolic disease, any benefits that they may otherwise have, as well as any adverse effects and any contraindications. So we'll start with tamoxifen. So tamoxifen, there is 2 options. You can either have a 20 milligram tablet daily for 5 years, or a 5 milligram tablet daily for 3 years. If you're on the 20 milligram daily for 5 years, it reduces their relative risk of breast cancer by at least a third, so 33% in both pre- and postmenopausal women. And this benefit lasts for at least 20 years, which is very significant. If they are on the 5 milligram regimen for 3 years, then it lowers their relative risk by at least 33%, but the benefit is not as long. So at least 10 years compared to at least 20 years for the higher dose and the longer duration of treatment. But there are no trials that directly compare the efficacy of 5 milligrams with the 20 milligrams, but the 5 milligrams is considered to be an alternative if the patient cannot tolerate the 20 milligram daily due to side effects. Tamoxifen increases endometrial cancer risk in postmenopausal women only. It does not increase endometrial cancer risk in premenopausal women, and the risk is said to be 1 in 250 extra cases over 5 years. Tamoxifen also increases the risk of blood clots, so venous thromboembolic disease. There is 1 in 250 extra cases over 5 years, so a similar increased risk to endometrial cancer in postmenopausal women. Other benefits for tamoxifen is that tamoxifen improves bone mineral density and reduces fracture risk, although it is not an indication for them to start tamoxifen, but it does help their bone health. It also helps to reduce breast density, which reduces breast cancer risk. It helps to reduce any breast tenderness as well that the patient may have. And it can often make periods lighter and induce amenorrhea, which may be of benefit to a few patients. The adverse effects of tamoxifen will be vasomotor symptoms, which occur in about 10% of patients. It's less common in the 5 milligram dose compared to the 20 milligram dose, suggesting that it is a dose-dependent effect. Examples of vasomotor symptoms will be hot flushes and night sweats. Tamoxifen may also increase the risk of cataracts, 1 in 250 extra, and vaginal discharge is a common side effect of tamoxifen. The contraindications for tamoxifen is they don't have a high enough risk of breast cancer for the medication to be worthwhile for them. If they have had a past history of bilateral mastectomy, because then they don't have any breast tissue for the benefit to be significant. If they have a past history of a blood clot, such as DVT, PE, or a thrombotic stroke, they should not get tamoxifen because tamoxifen increases their risk of blood clots. If they are smoking, we also don't recommend them to have tamoxifen because that increases their risk of blood clots significantly. If they are pregnant, breastfeeding, or they're planning a pregnancy within the next 3 years, then we also don't recommend tamoxifen. If they are planning on becoming pregnant and they are on tamoxifen, then they should stop tamoxifen at least 3 months prior to conception. If they are on anticoagulants, HRT, or the combined pill, we also don't recommend them to be on tamoxifen. And they're also on medications that are strong CYP2D6 inhibitors because that can have interactions with tamoxifen. Next is raloxifene, which is another selective estrogen receptor modulator. It is only used in postmenopausal women, so not for premenopausal women. And it is a 60 milligram tablet taken a day every day for 5 years. It lowers the relative risk in postmenopausal women in the short term, similar to tamoxifen, but is less effective long term. However, raloxifene has the benefit of not increasing endometrial cancer risk compared to tamoxifen. It also has a lower risk of venous thromboembolic disease compared to tamoxifen, 1 in 330 extra cases compared to 1 in 250 cases with tamoxifen. And just like tamoxifen, raloxifene improves bone mineral density and reduces fracture risk, but doesn't have as much of the other benefits in terms of improving breast density, tenderness, or making their periods lighter or amenorrheic compared to tamoxifen. Raloxifene has less vasomotor symptoms and less cataracts risk than tamoxifen, but has worse sexual dysfunction symptoms than tamoxifen. They also can have vaginal discharge, but again less so than tamoxifen. They have very similar contraindications to tamoxifen, so not high enough breast cancer risks, bilateral mastectomy, history of VTE, smoking, anticoagulants, HRT or COCP use concurrently, and raloxifene should not be used in premenopausal women due to a lack of data. The next will be the 2 aromatase inhibitors, the exemestane and the anastrozole. So we can compare both of them together side by side. They're both taken for 5 years and they're only used in postmenopausal women. The relative risk reduction for exemestane in the short term is 63%. There is no long-term data for exemestane, whereas anastrozole has long-term data where the risk reduction is 49% over 10 years. Exemestane and anastrozole do not increase the risk of endometrial cancer, and they also do not increase the risk of venothromboembolic disease. And this is in comparison to tamoxifen, which increases endometrial cancer and the risk of blood clots. However, exemestane and anastrozole do not help with bone mineral density, although there is a theoretical reduction in bone density with 5 years of daily use. So they may actually harm bone density and with long-term use. And so for patients who are taking exemestane or anastrozole, the recommendation is for them to have a DEXA scan every 2 years to monitor their bone mineral density. Similar side effects of vasomotor symptoms with exemestane and anastrozole. They can also cause joint aches and muscle aches, diarrhea, vaginal dryness, and anastrozole can also cause dry eyes and rarely carpal tunnel syndrome. The contraindications for both are exactly the same. So again, they don't have enough risk for breast cancer, disqualifies them from the medication. If they have a past history of bilateral mastectomy, if they are on HRT or COCP, concurrently, they should not be using exemestane or anastrozole. If they have a history of osteoporosis on a DEXA scan, with the result being less than 2 years prior to starting these medications, we should not start them on these medications because it can worsen their bone mineral density. And if they are premenopausal, because in premenopausal women there is a lack of effectiveness for exemestane and anastrozole in reducing breast cancer risk.